These things should be there in your mind before venturing into laser. Rest every procedure, every step is the same. Just like putting a stripper in, you can put a laser fiber in, but you should know how it works. Right. Okay. Now, the other topic. I think it will be very known to all of you. You are all surgeons. So, varicose veins. Why do we get varicose veins?
Upright posture.
We are walking on our feet. Because of upright posture, we are getting varicose veins. Why do we get hemorrhoids? We are sitting. So those things we have to always know. Varicose vein, upright posture and sitting is the culprit for varicose veins. Because I am telling that specifically because every patient after varicose vein surgery, they will tell, now I am keeping a stool in front of me and keeping my leg elevated. But their head is high. The thing is, head should be low and leg should be up. They have to lie down with their leg up. Only then the blood will flow to the head. It will flow away from the leg. Whether they are standing, whether they are sitting just like I am doing, or whether they are sitting and keeping the leg on a table or a stool or whatsoever, blood will get pulled in the leg only. It is not going to make any difference. Anatomy, I think, just brushing up anatomy. You all studied the anatomy. I think some people I think studied it some 14-15 years back, right, sir?
Yes.
Okay. There is a dorsal venous arch is there. From there, veins go up. Medial part, long saphenous vein, lateral part, short saphenous vein. That much is clear, right? All of you know about it.
Yes.
Just one thing I want to make you know here. Long saphenous vein is anterior to the medial malleolus, and short saphenous vein is posterior to it. So when you are puncturing, you should be knowing anterior to the medial malleolus is the long saphenous vein, and posterior to the lateral malleolus is the short saphenous vein. That is a point which you have to make it clear. What happens to the long saphenous vein after that? It goes like that. Here it is behind the knee. It is not medial to the knee. It is literally behind it. So this is the region where we have to search the nerve. Search the vein when we are puncturing it there. When we are putting a ultrasound probe and saying, yeah, this is great saphenous. How come we know it is great saphenous? Only because of the position. So just medial and behind the posterior aspect of the knee, you will get a great saphenous vein. Then it will come anterior. And this region, I think all of you know, where we make an incision for truncal procedure, right? There it enters all the three named tributaries, everything we know. There is two tributaries which are there, which we usually don't see in open surgery. One goes posteromedial, the other goes anterolateral. These tributaries are important only because in some patients, these may be dilated and the great saphenous vein may not be very much dilated. So if these are dilated, we have to take care of those dilated tributaries also. So just with the ultrasound probe, see how these two tributaries are, right? This can go posteriorly and can get anastomosed with a short saphenous vein, that is posteromedial one, which is called Giacomo, which I will be coming later. These are the three named tributaries. Only for keeping you not sleeping. Just you can tell me what all are the tributaries.
Yes.
External. No significance for us. Whichever the vein is, after all the veins, we have to ligate because these all veins should collapse. Otherwise, they will lead to saphenous varix. Whatever the name be, we are not interested in the names. but we have to ligate flush than that, flush to the femoral vein. That means at this region. Otherwise, this valve is damaged. So if we ligate it here, blood will continue to flow into this, and that will form a saphenous, right? This is the normal anatomy which I told. This goes behind. That is the thing which we have to keep in our mind. So this is a region where we can locate it easily, right? Now coming to short saphenous, it is posterior and it comes straight here. Here it enters the popliteal vein. In most of the people, there will be one more connection here, which is called Giacometti vein, which connects this short saphenous and long saphenous. The problem there is, even if we do a proper procedure, this will continue to dilate and varicosities will recur in the short saphenous course. We took care of the long saphenous vein, everything, but finally the patient will land up in varicosities in the short saphenous vein. That will be because of this anastomosis. We cannot use the term anastomosis because anastomosis is something which is used in arteries, but it is literally similar. Yeah, vein of Giacometti, which connects this with this. One more thing I will just go back. I wanted here to tell you is, there is something called a anterior arch vein and a posterior arch vein in the leg. This anterior arch vein comes in the anterior aspect of the leg and posterior arch vein goes behind. Most of the perforators are located on the posterior arch vein and not on the great saphenous vein. So when you pass the laser probe down here and fry, that probe will not get passed through all the perforators because they lie on the posterior arch vein. Right. At a lot of points, there is a connection between the deeper system and the superficial system, and they have got valves there. Because of one thing or another, this valve get damaged and varicosities do develop. So these perforators, there are named perforators, there are unnamed perforators. Named perforators are called direct one, and unnamed perforators are called indirect. Whether it be direct, whether it be indirect, whatsoever, it has no significance. If the reflex is significant, you have to take care of the perforator, whether it be direct, whether it be named, whether it be unnamed. So each patient you have to assess if a perforator incompetence is there, is that incompetence significant? Whatever be the name, that perforator needs to be taken care of, or else varicosity will recur. So forget about all the names and everything. The names are, I think you all know, Hunterian, Dodd, Boyd, Pocket, Mayakusta, whatsoever they are. Right? And about valves, these veins has valves which lead to unidirectional flow. Do we get varicosities in upper limb? We are always talking on telling we are doing varicose vein surgeries, and we are talking on leg. Why are we not talking on upper limb?
You don't get them.
Varicosities don't develop anywhere except the leg. And what we are seeing in the upper limb, that may be only reason is either a congenital some AV malformation or in a renal failure they have done a shunt. In both the cases, don't try to meddle up with that varicose vein because those will be the only flow which is there, and if you tackle it, you will be in a trouble.
So there is no.
You will be in soup.
So there is no deep vein.
Deep vein systems are there, but for some reason, in renal failure, we have created a shunt, and that is why these veins are dilated. If you block the shunt, then the other cardiothoracic surgeon, the procedure he has done is gone. And in AV malformation also, if you tackle those, it will be difficult because the blood will continue to flow there and you have blocked. So only tackle the varicose veins of the leg. Just forget about varicose veins if they are present in any other part of the body. If you are seeing varices in the abdominal surface, don't go and do a varicose vein laser surgery on the abdomen, because it will be a inferior vena cava or superior vena cava block which has got there, or it will be cirrhosis or something like that. Okay, that is why we are talking about anatomy of the leg and leg only. As varicose vein laser surgeons, you will be tackling leg only. Okay. Okay, then just every disease we need to have a definition. So if somebody asks you what is varicose vein, what is the definition? Dilated, tortuous, elongated veins. That is classical from our MBBS time. We were learning like that. Dilated, tortuous, elongated veins are called varicose veins. Can cause cosmesis, cosmetic concern. It can cause pain and discomfort, ulceration, everything. Itching can happen, heaviness can happen, skin discoloration, spider veins, can see telangiectasias, ulcers, and painless bleeding. All these are consequences of varicose veins. Right? Here you can see lipodermatosclerosis, that pigment deposition is there, and healed ulcers are there. Small scar is seen here. Those ulcers are very superficial. These are called a bunch of grape appearance. Right. Edema is there. Ulcers, they are very shallow and edges are not sloping, not healing, and unhealthy granulation tissue is there. And the other part is it will be severely paining. It is painful. Though looking very superficial, it will be very painful. Painful ulceration. That is the classic feature of varicose veins, and surrounding skin shows lipodermatosclerosis. Right? One more trial you can give to the patient. Give 4-layer bandaging, ask them to take 24-hour bed rest, at least for a week or two. Mostly the ulcer will heal. And as they step down, it will come again. Varicose ulcers heal if they offload, but it should be 24 hours. If you are in a doubt whether it is an arterial ulcer or a venous ulcer, just make a test before going ahead with the procedure, because some patients will have both, because Doppler is showing some small arterial disease, some small venous disease. You are confused. Then ask them to limb elevated 24-hour bed rest. If it is arterial, they will jump out of the bed and they will say, when I am lying like that, I am getting severe claudication pain. I am not able to. If it is so, you think that the ulcer is arterial. Only thing is, varicose vein needs to be operated, but you can preoperatively tell the patient this ulcer is related to something else, which you have to take medication for a longer period. It will not heal. Right? Similar part is about the pain. As I told, ulcer, pain also is something which you have to differentiate whether it is varicose pain or whether it is something else. Otherwise, after surgery, it will persist. Edema. Here in Alepi side and all, this filariasis is common. So it can be a varicose edema, it can be another edema. That also you should be very careful in telling the patient. Otherwise, the patient will come to you. They are coming for edema, they are coming for pain. After surgery, they are telling, doctor, it has not gone. Then before surgery, you have to clearly tell them what all will go and what all will not go. Right? And all these patients, they will have a typical appearance of the leg. That is the soleus part will be very much bulged, and because of repeated infection and scarring, that lower shin part will get contracted. So a bulge followed by a contraction, something like a club-like appearance it will be. What is the physiology behind? At capillaries, it is only 20. On standing, the venous pressure increased to 100. And on walking, the peak pressure increases to 200. That is, during contraction, it increases to 200. But during relaxation, it goes very low. Negative pressure, at that point, the sucking in happens. So the median pressure, if you check, median pressure during walking is slow, fast walking and running. It is 20 range. That peak pressure and trough pressure and the median is very low. So the peak pressure is high. That is why walking and running, whether it be slow or fast walking and running, is beneficial to standing in varicose veins. Because of this negative pressure, blood will flow from superficial to deeper system. And during walking, that will be pushed onto the heart. That is what is called peripheral heart or soleal pump, whatsoever we can tell. A patent deep vein, functioning valve, and walking is a must. Right. If there is a block, whether you walk or run, it cannot go to the heart. It can come to the, if the patient is having DVT, you cannot tell the patient go on walking. It will come to the superficial system only because there is a block. When there is a valve damage, that patient tells, okay, I will not go ahead with the surgery. I will continue with the walking. It will not make any good because that incompetent perforators, when walking, the pressure goes 200, blood will come out because the valves are damaged. They will come out. So, absence of obstruction, presence of functioning valves are a requisite along with posture modification, exercise, all those. If there is a valve damage, either at the saphenous junction, saphenous-popliteal junction, or in the perforator junction, perforator region, those valve damages should be taken care of by surgical method. Exercise and posture modification will not help. Right. Smaller veins are called thread veins. Then comes spinal veins, telangiectasias, like that. Based on the size of the veins, we call it with different names. Sorry, these veins we are not that concerned in laser procedures because what we are concerned is here taking care of the varicose veins. Once these veins are taken care, these will go. But sometimes small telangiectasias will persist. Sclero can take care of telangiectasia to some extent. If this spider veins are to be gone, there are some specific lasers with very low wavelength which can be absorbed by this. Yeah, laser machine is there of which we can do like that and spider veins will get shrunk. Dermatological laser. So if a patient comes to you with a telangiectasia only, no varicose veins, don't try to do a laser. This procedure, that is EVLA, for that. That should be dermatological laser you have to use. Observation and classification, a basic of scientific method of learning. Do everybody need tea or something like that? Can you ask somebody to bring something?
So I will come back.
Yeah.
I'll inform them.
So scientific method, we all tell it is nothing but old age. We had a big heritage, but what is the present thing about science? Our old age, like Sushruta, everybody, they were doing a lot of things. We know about it. But science has overcome our old tradition. Why? Only thing is, you can replicate. What I do, if I tell you, you can do the same. That is what is science. But the other thing is, it is something like magic. If I keep a hand over your head and I say you are getting cured, you won't. But if you go to Amritanandamai, Amma is keeping head and telling, yeah, you are cured now. How it can happen? That was our tradition. And there were good people also in that period, but the observation and classification was not that meticulous in that period. That is the reason, while documentation, everything, it was not that perfect, and that is why science has surpassed our tradition. Let it be not only Indian tradition, but Greek, whichsoever tradition, Egyptian, every civilization is lost because of science. Science has brought everything under the same roof. Let us classify the varicose veins now. Come back to varicose veins.
So 5 minutes, probably they don't have milk, so we got milk for them. 5 minutes.
Okay. Because my topic is so good that everybody is sleeping. There are a lot of methods to classify. There is something called primary varicose veins and secondary varicose veins. Primary means there is no cause. We don't know what is the cause. That is the better way to tell. But we can use the term idiopathic or whatsoever, because in insurance and all, they will ask, what is the cause? Then we will put idiopathic, means idiotic to the... Okay, whatsoever, that is it. We don't know the cause. It is a better way to tell, I don't know why it happens. That is primary. It is because of valvular insufficiency. It is because of the weakness of the wall of the vein. Collagen problem can be there, but a patient is sitting in front of me. Doctor, why it happened to me? Can I tell, look and tell it is collagen problem or it is valve problem? I cannot. So I don't know. What are secondary varicose veins? There are a lot of causes like deep vein thrombosis, pelvic mass, AV malformations, congenital diseases like Klippel-Trenaunay syndrome, rare cases of cardiac failure like tricuspid regurgitation, where you can have pulsatile varicose veins. These are all secondary varicosities. Don't touch these varicosities. Deep venous thrombosis you can tackle once the deep venous thrombosis is controlled, at least 1 year of WAF, and then veins are recanalized and varicose vein is persisting and it is causing symptoms to the patient, then you can take care of varicose vein in a DVT patient. Similarly, pelvic mass, remove the mass first. And if the varicose vein doesn't regress, then you can go ahead with the varicose vein surgery. We also had a patient, 6 months or 1 year. We had a patient, we regularly do USG abdomen for every case of varicose veins. In an ultrasound, in the pre-op day, because for insurance, they will get admitted and do all the tests. Pre-op day night, when I went for rounds, I checked and there is some mass which is stored in the pelvis, and that is a huge mass. So the case was changed from varicose vein surgery to we changed over to laparoscopic mass excision, pelvic mass excision. It was such a big mass, which was liposarcoma. And luckily, after 6 weeks or so, when in the review, varicose vein subsided. That is what is about pelvic mass.
When you said in tricuspid regurgitation, the pulsations are coming very close. Would pass out till the
Yeah, there is documentation in tricuspid regurgitation, cardiac failure due to tricuspid regurgitation, pulsatile varicose veins. It is very rare phenomenon. I have not seen it, but it is documented that pulsatile varicose veins, if you get, you have to think about cardiac vein. And the radiologist, last day, the presentation, he was specifically telling in doing echo for every case of varicose vein before surgery. Go ahead with an echo test.
also provided you this was.
Yeah, can be. Then comes two different entities for which EVLA is not that much indicated. One is capillary veins. I already told you a dermatological thing is the probe is there. With them itself, the probe will be there. With that probe, you can do it. No need to refer to a dermatologist. There is a probe separate for that. Now, I think Dr. Razan has clearly told there are hybrid machines which have multiple wavelengths can be attached to the same machine. You have to change the wavelength and use it. Change the probe and use it. And 8th group, people will come to you very gym body, no fat at all. You will feel jealous seeing them, right? And they are telling, sir, we have varicose veins. On seeing, it will be a straight vein. There won't be tortuosity. There won't be dilatation. The skin, no issues are there. On Doppler scan, it will be reported as normal veins. They are just hypertrophic veins because the subcutaneous fat is not there. Similar issue happens in old age or malignancy and all. When the fat gets dissolved, the veins become prominent. Don't think that as varicose veins, right? So this is a rough classification. I think clinically very useful classification, which we have to keep in our mind. Then comes a second classification, which is called CEAP classification, right? If somebody talks to you for varicose vein, they will ask about what is CEAP classification. That is the thing now. CEAP, C is clinical classification, E stands for etiology, whether it is congenital, primary, or secondary. A stands for anatomic classifications, whether it is superficial veins, whether it is involving deep veins, whether it is involving perforator veins. And pathological classification, whether the cause of varicose vein is obstruction, that is deep vein thrombosis or mass or whatsoever, and whether it is reflex, or whether there is obstruction plus reflex. Because obstruction will be initial thing, DVT has happened, valve got damaged, then reflex is happening. So both the entities are there, right? So this helps us in, it is a crude form was shown initials in the previous slide. This is the proper scientific way of explaining those things. And this has two different entities, which I had not shown before. One is clinical and second is anatomic, right? In the anatomic, can you see there is something mentioning called a deep veins? Why I have mentioned it like deep veins here? Yeah, because obstruction is told to be a cause, and which vein is involved? Is it deep vein? That is one thing. And for a deep venous reflex, that need to be examined. That was clearly described by the radiologist in his class. Deep venous reflex is something, if it is there, whatever you do on the varicose vein, the patient will have recurrence of symptoms, recurrence of varicose vein. So the radiologist who is doing the scan should specifically tell you whether there is deep vein thrombosis, whether there is deep vein reflex. That is must. Ultrasound abdomen is a must. Echo is a must. I think is that message clear? Yeah. Forget about every name of the perforators or whatsoever, but this small message should be there, imprinted on your brains, right? Yeah. And now let us go to what is clinical classification, right? How much the patient is diseased with varicose vein. That is also very important before telling treatment to the patient. Grade 0 to grade 6. Grade 0, no varicose veins. What is grade 1? Minor, telangiectasia or flare. Varicose veins per se, you are seeing simple varicose veins. It is 2. It can be 2A or 2S. What is 2A? Varicose veins without symptoms. Varicose vein with symptoms. The patient has some dull pain or something. Then it is 2S. varicose vein 2A and 2S. Simple varicose it is. Even conservative treatment you can advise for this to A group. When it becomes to 3, edema is the first thing to develop. On vision, you will think there is no edema, but try to elicit pitting edema above the medial malleolus. Right? If pitting edema is there, it is 3. When it is 4, skin changes are there. What are the different skin changes which we see in varicose veins? Just tell. No need to look there. You all know it. That is what is called lipodermatosclerosis. Right? Then,
Ulcer.
yeah, that everything comes under lipodermatosclerosis. Ulcer doesn't come there because it is next stage. Then what? Any other skin changes you know? Some will appear just like oozing eczema like thing in the lower shin. Some people, they come down with a dry lipodermatosclerosis. They come with a weeping skin. It is not an ulcer, a weeping skin, eczema. So eczema can be there, lipodermatosclerosis can be there, and there is something called corona phlebitis. Can you see this type of veins? They are all pointing veins. Right. It is called corona phlebitis. So if these 3 things are there, either any of these 3 things are there, you can call it 4. So initially edema, skin changes is 4. Once it ulcerates and the ulcer heals, healed ulcer is 5 and active ulcer is 6. Right? Is that clear? Yes. So this 4, you can also say skin changes are there, or 4, you can also say impending ulceration, because ulcer is something which is important, and these 3 things are impending ulceration. At any point, the patient can develop an ulcer. So impending ulceration is 4, edema is 3, impending ulceration is 4, healed ulcer is 5, and active ulcer is 6. Clear? Because whenever you see the patient, document it accordingly. That is, the patient is having C6 or C5. Because at times when it goes to court or something like that, what you have documented will help you. Patient will not help you. The money the patient gave you will not help you, because he would have given you some 30,000, 40,000, while he will be suing for you for at least 1 crore or so. So that money will not help you. Nothing will help you like that. But your documentation will be helping you. Just like 2A, 2S, you will be giving a subscript of R if the ulceration is recurrent. Similarly, there is something called disability scoring. A patient is asymptomatic, and rest 1 to 3 it is symptomatic, S. But S1, they can do their daily activities without any rust. 2 is they can do daily activities, but in between they will have to keep their limb elevated. 3 is unable to do the daily activities even with limb elevation. This also you need to document, because otherwise after some 5 years, 6 years, the patient is having just paresthesia where you have done the procedure, absence sensation or something like that. But they'll be telling, I had no disease at all. I went to this doctor did the procedure, and he is telling that everything is becoming fine. Now I lost the sensation. But if you have documented, he was even unable to perform his activities, his disability score is 3 or so, that documentation will help you out. Right? Clinical features, I think already all these are dealt with. How to do the ultrasound? A good radiologist should help you out. Get the help of good radiologist. Let him do a preoperative ultrasound scan and document all the features which I told you, our requirements. Then let him do the immediate pre-op day. Again, let himself do the ultrasound and mark all the perforators. In the initial stages, if you are not that confident on an ultrasound, just ask him to come to the theater to help you out. Maybe after 4-5 cases, you will be able to do it on yourself. Because in the theater, no much role for the ultrasound. Which disease is, which vein is having most disease? Because the patient can have ulcer. There will be lot of veins draining that region. One of that vein will be having a disease, perforator incompetence. You took care of everything else, but that vein, if you miss, it is good that you did nothing. As good as you did nothing. So that anatomical, every aspect should be taken care and every vein should be taken care, right? Duplex ultrasound, everything. Now coming to treatment part, there is something called conservative management. As I already told, 4-layer bandaging, leg elevation, posture modifications. Always preoperatively itself for some time, make them do that. Then after postoperative period, you can continue it. Then comes sclerotherapy, surgical, and laser. Surgical part I am not at all going to discuss because you are all well familiar with how a Trendelenburg procedure is done. I think sir can teach me how a Trendelenburg procedure can be done, right? That many numbers you would have done, stripping everything. I will be talking on the plus minus of these procedures. And after this, Dr. Rasan will be telling you what is this, how to do a sclero and how to do a laser, right? What are the indications for sclerotherapy? Telangiectasias can be controlled with sclerotherapy. Reticular veins. After surgery, that is recurrent varicosities or isolated varicosities, a single varicose vein is there. Sclero is good. Then below knee varicosities, sclero is good. And short saphenous territory, sclero is good because that short saphenous vein is deeper to the fascia, lying very deep. And I think if surgically you would have tried, it is very difficult to find out the short saphenous vein. Great saphenous, it is easy to find out. It damages the endothelium and forms a fibrotic cord. This method is called Tessari method, how to prepare a sclerosant and how much to dilute, whether better is to dilute it with air. Water also can be used. But it has got a high recanalization rate for larger veins. But it is cheaper. So plus and minus. High chance of recanalization is a minus. It is cheaper is a plus. Right. Coming to laser. This laser ablates the endothelium and it forms into a fibrotic cord once it heals. EVLA, endovenous laser ablation. Some tell it is EVLT, endovenous laser treatment. It is thermal ablation. As we discussed later, laser, it is a thermal ablation of the endothelium. Recurrence rate is less than 3% after 5 years. The procedure will be dealt with. Don't take it is a separate PowerPoint is there on how it is done. With steps it is there. EVLT procedures, I'll just skip through. Radio frequency ablation and laser. Always people tell about whether what is better, whether it is radio frequency ablation or whether it is laser. I will always go for laser only because the final part, that is the patient who are undergoing the procedures, that community is selecting the laser. So it should have something in that for the people to select laser onto radio frequency ablation. Just like open surgery is there, laparoscopy is there. Before surgeon selected laparoscopy as the best, community itself selected laparoscopy as better to open surgery. Because patients know the benefit of the procedure done to them. Likewise, laser has its own benefits which the patients can perceive. I had when we are doing surgery, this monopolar and all, we get cautery burns. I had burns when I started laser initially. That is for proctology. I had burns in my hand. Just as I told, it was once I had it in my leg because the laser machine was hanging like this. Unknowingly, for monopolar, I pressed laser. It was on to my foot. And other time, I had with a bare fiber, I had a burn on my dorsum of the hand. Did anybody had monopolar burns? How long it will pain you? At least a month. This didn't hurt me at least for a day. When I saw there was just a shade which just went off in a day or two. Evening itself, there was no pain at all. That much pain-free the laser is. Why it is so, I don't know. There is some mechanisms being told like laser, it doesn't affect the nerve or affects the nerve. Lot of postulations are there, but laser has got reduced pain. At times, laser causes more pain. That is, especially it is important when you are doing laser for proctology, when the amount of energy delivered goes more. That you should be very careful about. There is a very small subset of patients who tell more pain even than open surgery. So that energy delivered should not go more than what is recommended. That total energy you should be very cautious about when you are doing laser. It happens only in proctology, and proctology is not my domain now. So we'll come back to varicose vein. Surgical stripping, sclerotherapy, radiofrequency ablation, and laser ablation. The radiofrequency fiber, it is very thicker when compared to the laser fiber. So laser can go more, radiofrequency better than radiofrequency. Success rates. But when we go to the scientific things, there is no much difference being told about. Both are told to be equally effective. But when you tell radio frequency to the patient will ask, doctor, is it laser? They will just ask only one thing, is it laser? They won't ask if it is radio frequency. Every procedure has got its own complications. There is neuralgia, bruising, infection, hyperpigmentation, pulmonary embolism, everything is being told. Everything understand you can tell for any surgical procedure, but do it in the right way. You won't have any complications. Everything will be perfect. In this region, there is something like when it comes to laser, what people always tell is laser, you can do it as an outpatient procedure and anesthesia is not required. It was there in some slide, which I am not seeing now. So anesthesia is not required for laser. You can do it under local anesthesia. You can do it as an OP procedure, but don't venture into it because infection is something, vasovagal syncope develops in OPD. It is something which is very difficult to manage there, though vasovagal. But if it is in the OT, you are very safe and you are protected. So always, any minor surgeries, even sebaceous cyst, do it in the theater. Because why we should risk ourselves and what gain we do get with that. Tell the hospital people, I will take only this much time. So I want to do it at a minor procedure in the OT. I want to do it at a lower cost. And get it done in a lower cost in the safer way. Rather than risking yourself into that. So I will be always preferring anesthesia for that. And I'll be doing all the pre-anesthetic workup even for a laser surgery. And it will not be done under local anesthesia. It will be done under proper anesthesia because you will have to make some 10 or 20 pricks or something like that. Small incisions you may have to make. Some perforator which laser cannot take, you can take with a small incision. Those things you can do if it is under anesthesia, but you will not be able to do it under the OPD. So management of saphenofemoral junction incompetence because the vein, if it is very much dilated, may not be taken with a laser. Perforator vein incompetence. Most of the perforators can be taken with laser and distal veins, they can be taken with sclero also. So just like you want everything, like battery is there, hybrid car, battery is there, fuel tank is there, petrol as well as electricity. This laser also, surgery has got its own benefits. Laser has got its own benefits. Sclero has got its own benefits. Laser fiber cannot pass through small telangiectasias, small branches, but sclero can pass through. Sclero is cheaper. Like that, each has its own benefit. And the leg of a patient in the varicosities, if you map the varicosities, there will be a lot of varicose vein, some getting controlled better with the surgery, some getting controlled better with the laser fiber, and some getting controlled only with the sclero. So do a combination of all these for the patient. That is what is called a hybrid therapy or triple therapy, where all these methods you can combine and give a better outcome to the patient. Thank you all. Are there any queries you can raise now? Let them bring the coffee also.
Hi, good morning. Myself, Dr. Padma Kumar. I had some other two functions, so I just got delayed. But I'm sure both of them will take you through a very descriptive format of varicose vein treatment, lasers, and other modalities. Just a few things which I heard what Dr. Pai did a wonderful lecture. Short saphenous system, though he's telling it is deep, that towards the saphenopopliteal area, it is deeper, and you will have access at a little more lower down and the periphery. You should target that, and if you want to actually like a saphenofemoral, you will not be easily accessing. That's what you should tackle it with another source or method of treatment. That's what he highlighted. So you should think of doing it from below rather than at the saphenopopliteal junction. It means ligation or something you don't have to try. You can do either laser if it's a longer vessel, if you're identifying lower down, or you should resort to sclero. That's what he meant by telling that it's deeper and it may be a little difficult to access. Then
difficult to access with surgery.
Yeah, with surgery. So that is the thing. So you should use other modalities which are easily passing through, even with a low.
Rather than not doing anything for that.
You
When
should.
it is open surgery alone, we usually do saphenofemoral and perforator, everything we do, and short saphenous we just ignore.
Yeah, that is because
popliteal
saphenopopliteal junction is something which is difficult to access. So you have other modalities which can be accessed from lower down toward the ankle or leg portion. Another thing, though he said ultrasoundologist, radiologist should mark those vessels and the junctions, perforator incompetence. In the OT, make the patient stand and mark the linear aspect of the vessels. Sometimes, as he said, there will be smaller vessels in the periphery, in the popliteal area especially, which will not come in the main things, and it may not have major perforator incompetence or something, but if you mark it, you will be able to give 2 cc of sclerosant. So if you mark it in the OT, what happens is patient is lying down. Sometimes in the trundle position, you may not see these vessels. When the patient stands, again, he will feel that the vessel which was there prominent was not taken care. So you mark it beginning itself, then you put your scalpel insert or something and just put 2 cc of sclero. That will be taken care of. So remember to make the patient stand, and the long route of the vessels, just mark it. So some point you'll be able to prick and do that injection thing. So just make sure that it is done. Then regarding laser, why he was telling it is less damaging is mainly because the tissue damage is less with such energies. It's like cautery, which is 400 degree, which is burning tissue, versus this ultrasonic energy, which will have 100. Similarly, the laser, the penetration, unless you apply for too long a time, it is a surface thing. Sometimes it is used for surface cautery also, no? So the depth of penetration is less, and so less tissue damage, and definitely you will have lesser pain. So it is mainly because of the it is a less invading type of an energy that you should understand. That is why we are keen on applying all kind of things. You cannot just put one inside the vessel and go on frying that, because the energy dissipation will be more kind of a burn will happen. This one will be limited to the endothelial damage. Maximum it may come out and affect only the soft tissue, which you are covering with your cold compress or even a Tumescent injection. Then regarding anesthesia, Engage one more person. What is the big thing? You are sharing your responsibilities regarding the patient. Naturally, you will have to share the income also. But definitely, if it is done under anesthesia, you will be able to charge the patient as well. The amount which you are spending for the anesthetist in the OT, patient will definitely give. If you do it in the OPD, if you charge 5,000, you will be able to charge 15,000 or so if you are doing a procedure in the OT. I don't think anybody will just go off. Fast and things are fine, maybe for a small segment of patients, but majority of them will actually willing to pay and get the best of treatment for the disease so that they don't have to go for treatment again and again. So do a good treatment, especially what he's telling of a triple therapy. Ligate the saphenous junction just by a small incision, because anyway you are using the ultrasound, you'll be able to locate that. Just 1 or 2 centimeter incision, you can ligate it so that the clot doesn't actually go in for an embolism, the sclero doesn't go, and the recanalization chances are made into 0. The other one is like a percentage only. Here there is no percentage. You can write 0 because the vessel will not recannulate if you are ligated and divided. Saphenous will not anyway affect. So that will actually contribute to 70 to 80% of the success. Then only the other peripheral things and perforators and things. So that is very important. If all these are possible, if you are done, and even if you try giving a sclero injection, no, it is painful. Patient will have that disturbance. So make them comfortable. Just 24 hours, morning you admit, do the treatment, next day morning you can observe and send them, avoid all these complications. The additions expenses are like very, very negligible. Do a proper treatment, they will be actually ready to do it. Insurance, all those things will be possible if you admit and do a proper procedure. Definitely this tissue triple therapy advantage, all those he has mentioned. Let us listen to Dr. Vasan Rajan. He is consultant surgeon at Lakeshore Hospital. He is at Keyhole Clinic on training faculty as well. He is well versed with laser, its energy and other things. They will address.
So I request, we are supposed to catch our trains early.
By what time? By what time?
3 o'clock is our train.
2:30. That will do. 2 will make you free. You can decide on lunch.
Yeah.
You are from which place?
Andhra Pradesh, sir.
We'll tell them to start anesthesia.
So just going through fast through the procedure, how we will be. The laser machine we will be using. The laser machine we will be using. It's one of the photon and the lasertronics machine. Then the laser probe used will be radial fiber. We have discussed already this. So preoperative.
What is that? 1 in the first picture. Yes.
This one. That is, yeah. It's showing watt, no?
Yeah.
That is the power. And we can adjust the time also. So the watt and time adjusting will result in how much energy or the joules will be delivered. So setting for will be 8 watts in upper thigh. Then around knee region we will use 6 watt setting, and the lower region we will use 4. And the timing for easy remember we will make it as 8 seconds, 6 seconds, and 4 seconds. Okay, so 8 watt for 8 seconds. So that will deliver 64 joules. Again, 6 watts and 6 seconds. So 36 joules in the mid knee region. Again 4 into 4, 16 joules in lower leg region. So easy to remember that part. Depending on the caliber, because upper thigh it will be vessel will be of larger size, and this is a normal setting we are using. We can either increase it like 8 joules and 10 seconds or 8 joules like that also, because we can assess clinically how the vessel is getting sealed with the crackling sound and the catch we are getting. So based on that we can reduce or increase also. In very much dilated veins we may have to increase the energy delivery, but better stick on to 64, I mean stick on to 72 joules maximum. Beyond that we don't usually give in the upper thigh. Lower obviously it should be reduced. Preoperatively we should do a duplex scan of lower limb for all the patients to assess the level of injury, I mean level of the damage for the perforators and the dilated veins. Ultrasound abdomen to be done to rule out any pelvic lesions which is causing secondary varicose veins. Pre-op blood investigations for anesthesia should be done. Preoperative marking of saphenofemoral junction, saphenopopliteal junction, and incompetent perforators by a radiologist will be beneficial during our surgery. Procedure should be done under general anesthesia or spinal anesthesia. We have to prepare Tumescent beforehand, which is made by mixing sodium bicarbonate with lignocaine in 500 ml NS. So 10 ml sodium bicarbonate and 15 ml lignocaine, 2% lignocaine.
Wait.
Intraoperative, the patient is kept in supine position. We should clean and drape the region. Just from below the umbilicus we have to drape. Just below the umbilicus we have to drape. Drape means the groin area should be exposed. Under ultrasound guidance we can locate the saphenofemoral junction. The typical appearance will be a Mickey Mouse sign, and here the face of the Mickey Mouse will be formed by femoral vein, and one of the ears by this face will be formed by the femoral vein, one of the ears by great saphenous vein, the other will be by femoral artery. So common femoral artery, femoral vein, and great saphenous vein. So that will form the Mickey Mouse. Right. We will be cannulating the great saphenous vein by the Seldinger technique. So that shows the sheet with the probes. First procedure, we will be puncturing the great saphenous vein. The procedure is anterior to medial malleolus. We will locate the great saphenous vein.
This Mickey Mouse sign is seen in the ankle.
No, it's in the groin. Saphenofemoral junction may be marked by Mickey Mouse.
That is great saphenous vein, the femoral vein, and the femoral artery. So these three actually forms each side.
Great saphenous vein may be punctured at the position 2 centimeters anterior to the medial malleolus. Here usually the skin will be soft, but in case of severe lipodermatosclerosis patient and all, this will be difficult. Always try to use, we can put a tourniquet above, and ultrasound probe, the linear probe may be used to locate the vein. And under US guidance, we can cannulate the vein. At the angle. We are cannulating from below. Steps like if we can cannulate the GSB without ultrasound guidance, it's well and good. Just like putting any other cannula. If it is not possible, especially in thick skin people and lipodermatosclerosis, we can try with the ultrasound guidance. Hold the ultrasound probe on the left, keep it steady, and using the right hand, aim the vessel, go in an angle to put the cannula inside the vein. We can see the spot of blood, venous blood, not bright color. That confirms we are inside. Once the cannula is in, take the operator out. Then the next step will be inserting the guide wire. Guide wire is having two ends. One will be the stiff end and the one will be the soft end. Always make sure we are putting the soft end inside the guide wire. And once the guide wire is inside, we can remove the cannula out. Then we will be putting the sheath over the guide wire. This is the sheath. We will be putting the sheath over the guide wire. Once it is near to the skin, we can use a number 11 knife to make a nick on the skin so that the entire sheath will go inside. Make sure the tip of the guide wire is still outside so that we should not miss the guide wire. Take out the guide wire. Or
Like a central vein, like.
typically like a central vein insertion. Typically, yeah, exactly like that.
When it is being put, the other hand should hold the.
We should
guide
hold
wire.
Pull down.
Otherwise, the guide wire, everything will go in.
Good, correct.
Anyway, you're a surgeon, it's okay.
Yeah.
Now open the tip, make sure free blood flow is there. And once the sheath is inside, that is fixed there. We can cannulate the same method. You can just position the patient and cannulate the short saphenous vein in the same manner. Keep the leg rotated. We can use again tourniquet or assistant can hold on the leg a little above so that we can cannulate. Then once the sheath is inside, we can use the radial fiber with the light switched on. Before that, make sure the fiber is intact. Using your hand, make sure the circumference is full.
So first we cannulate both the veins before we start the procedure. Or we can go.
Cannulate one after the other is also okay. Radial fiber should be going through the sheath. Keep the OT lights down so that we can easily see through the skin where the laser fiber is going. Keep the OT lights down. And make sure we are seeing also. If we are puncturing the vessel close to a perforator, it can go into the deep system. Then we won't be seeing any light. If we are not seeing any light, make sure we are not at the superficial.
Because sometimes what happens.
Stone also.
Never should be switched on.
What happens is the perforator will be very much dilated.
Very much dilated.
So instead of going through the great saphenous vein, it will go through the perforator into the deeper vein. So in the femoral vein, it will go and it will reach.
Yeah.
So once we are advancing the laser probe, make sure we are seeing a light just below the skin. If it is deep vein, we won't see any light. Also, we can go slowly. We can reach up to saphenofemoral junction, and beyond that, the light won't be seen because it will be inside the perforator. I mean, inside the femoral. Then we can pull it back.
And in the sheet also there are markings, which is already told. Every centimeter there will be a mark.
Yeah.
And when it reaches 10, there will be a big mark. Then when it reaches 20, there will be 2 bars, 30, 3 bars. Like that it goes. So at least you can understand how much is the length of the leg of the patient, and that much it should go in. It should not cross the saphenofemoral junction and
Go beyond.
Not put like.
As we can see you can see the light here, no? It's close to the femoral junction, saphenofemoral junction. The light is seen. So that is a guide. Using ultrasound probe again, we can locate the
Obese patients, it's seen.
obese patient also. It's a little difficult. Then keep the OT light more down.
Okay.
If it is not seen, you can just put an
Use an ultrasound probe and you can make sure.
locate it. When you move, you can see.
Yeah.
In the I think the light, right?
Yeah. And one of the disadvantages for RFA is that
it doesn't have this light.
we have to always
nothing
use
like
the
that.
ultrasound to locate it. But even if we in laser, because of this light, we can locate where the probe is. This can guide us even for infiltrating the Tumescent and all. So once the laser fiber is inside, here you can see that this shadow, no, this is cast by the fiber inside. next step will be Tumescent infiltration around the vein. Tumescent we have already prepared. That we have to already put. It's prepared by 500 ml saline and 10 ml sodium bicarbonate and 15 ml lignocaine. So we will be here again. You can see the light is light is seen through the skin, and we usually use a spinal needle. Two methods we can use, either using a spinal needle and connecting to an IV, or other method is taking in a 50 cc syringe. You can also infiltrate, but this one is the best method, easier. Under ultrasound guidance, you prick the skin above the vein, and you infiltrate this Tumescent solution between the skin and the vein. So it has got two effects. One is this will be spreading around the vein, and this will prevent dissipation of energy to the skin or the surrounding tissues. Second thing, it has got a cooling effect. Post-operative pain less is there. This cooling effect, while during the procedure, we will be able to show you again. The cooling effect will prevent surrounding tissue damage, and again this fluid around the vein will be giving an external compression. So this will aid in collapsing of the vein.
Surrounding tissue means otherwise you can tell it is the saphenous nerve.
Yeah.
That we are concerned about. No other thing is there, only fat is there.
This is ultrasound image. You can see the this is the vein. Okay, this is the sheath. So that is casting a shadow here. Okay, vein, sheath inside. This is casting a shadow, and we are infiltrating the Tumescent around the vein. It's more clear here. Vein is here. Tumescent solution is here. This is giving an external compression also.
So how often would be, prone to injure the nerve? During a procedure.
It's better not to.
Better not.
How often will be encountered?
What's your experience?
Because I heard one of my bosses in Vascular he said it is that nerve which should be taken care of, every time. So he stressed it. So I just, for my curiosity, how often, how to prevent, rather than my question is, how to prevent,
Injury to the nerve.
injury to the nerve.
It is above knee. The vein and the nerve are separate. Usually it is very less often we do encounter the nerve. If we do up to just below knee, if we stop the laser.
Okay.
But what happens is, if the perforators are dilated, that is during surgery we take a thing, whether we have to pass the probe till the ankle or not. So if the perforators are very much dilated, below knee, if you give scleral, the patient will land up in DVT. That means you are between two things, and based on the patient, you have to take care which one you have to select when it comes to below knee. Laser probe can pass easily up to the medial malleolus. So whether you have to pry it between the knee and the medial malleolus with laser, or you have to give scleral, that is a thing which you have to think on at that point of time. Whether if the patient develops DVT, what you will go and tell the patient, based on the patient, based on your relation with the patient. That is, you would have talked with the patient, and somebody will be very much bothered about the sensation. Somebody won't be bothered about that much about the sensation. Their social strata, everything you have to consider at that point of time, and then take a decision whether you have to go below or not. And when the Tumescent is injected, if you are going below knee, if you are injecting the Tumescent onto the sheath of the vein, you have to inject the Tumescent. Then what happens is, rather than injecting it everywhere else, under ultrasound guidance, you can inject it onto the sheath of the veins, so that you will see the vein itself. The picture which it was shown, that black was literally the vein, and inside a white rim was the collapsed vein wall, and inside was the probe. Because the Tumescent was given in the sheath of the vein, then the nerve will be separated and the nerve won't be injured. But if you missed it, and sometimes the poking will be below or above, or it will be lateral to the nerve, so that the nerve will get and you can develop. There is a chance of no issue. How much ever we do take precautions, there is a at least 1 or 2% chances that the nerve can get injured. That nerve means sensory nerve.
And definitely reducing the energy as you go down.
Yeah.
That is always done. Like 8 into 8, you are selling 64. Should be brought down to 6 into 6, 36. Not even half. Not even half.
Yeah.
And little more towards the angle. If you are very particular, you should use an energy. Then it is still brought down to 4 into 4, 16. So it's not even half. You are reducing it so much that it will affect only the vessel, and it may be a good practice, especially in a thinner individual, to put proper Tumescent, make sure that all around vein it is there, and do that.
And whenever we are pulling out the thing, in between you will be pushing in gently, very gently, because you should not puncture it.
Okay.
If it is easily coming in and going out, that means that endothelium itself is not damaged. Only in that case, you will be doing it for the second time. When you are doing it for the second time in the
You understood what he said.
it goes 64 plus 64.
All of you understood what you are telling, this movement of fiber and endothelial damage. What you are telling is, if it is fully taken care, treated vessel, it will not permit your probe to go in further.
Yes.
If it is very easy, that means it was not that ideally treated. That the heat energy dissipated was not sufficient to damage the
Only
epithelium.
then you will do it for
Then-
second time.
then
That's the
second
double
time you have to
is
apply.
there, but it is not even damage the endothelium, right? So it will not go into the nerve.
So you should make sure that your sufficient energy is given to a particular area, and we call it as a catch. When you are just pulling out the fiber every time, there should be some resistance.
Yes.
Some this popcorn frying, that sound, bubble, the cricket sound that it should come. That means you are treating, especially in the upper portion, maybe above knee. You should definitely make sure some sound is coming, because that is the area which you can safely treat, and that is the area which will actually contribute to all other areas, varicosity. So treat that upper thigh. That is very much important.
So, patient, when do you start treating what level do you start ablating the vein? I mean, right from the
Saphenous emergency.
right from
Just below the SFJ.
SFJ, and that too, the best part which we are telling is, people have hesitation using an energy near the saphenous junction. We don't have, because we are already ligated. Max what we are doing is to the upper end of the vessel. Yeah, we are trying to ligate the saphenous junction. That's what.
Open and the ligate.
Yeah, 1 centimeter, 2 centimeter incision, ligate, disconnect. That's what I said. You are doing a 100% treatment of the saphenous junction. You don't have to trace the tributaries, all those. Saphenofemoral flesh ligation is done towards almost the area where you are reaching, and you have a tie there. Even when you have difficulty cannulating from below, you can use it for reverse thing also. These are facilities only for surgeons. Radiologist or interventional person, nobody else will be able to do that. You will be able to cannulate the vessel from top. Sometimes that will go into the proper vein, rather than when you try, especially with dermatosclerosis, all those, you will find it very difficult to pass through that area. Ulcer is there, but vessel will come from top to where actually it should reach, till the area of that vessel, means the ulcer or something, it will reach. So that will be another trick also. Anyway, you are ligated, as well use it for passing the
The other day, I was just talking to the radiologist who's doing this. He said he need to leave because he's not ligated. So he said, at least the 4 fingers of yours from the SF junction, you leave and start upgrading. That's what.
That is their fear. We are not afraid.
I think classic teaching in surgery is
Yeah.
whatever the varicose
Should we
veins do a saphenous junction ligation.
Tributaries are not being taken.
Even if it is told to be
Yeah.
no incompetence is there, only perforator incompetence is there, tackle saphenous junction because it prevents recurrence.
Correct.
That is like good old teaching in the surgery part. Likewise, tackle saphenous junction. And second thing which I will tell you is, you told open saphenous junction ligation. That word open, I will just contradict there. It is not a proper saphenous junction ligation as we do it in the open surgery. It is located under ultrasound. Make just 1 centimeter incision there, take it out and flush ligate the saphenous junction and divide it and leave. Don't take each branches, coagulate like that.
Just flush like.
Just
I think
like
it's a
that.
venous cut down. You are not able to access and you've done a venous
Yes.
cut down, no?
So
That
that
small
means
incision
the
cut down.
discontinuity is there. Then the second part of saphenofemoral junction ligation, that is frontal procedure, is excising 7 centimeters vein from the flush ligation part. At that point, you want to take all the tributaries and you are excising a piece of skin that you will tackle with a laser from below or from above.
Yeah. Yeah.
So that is why you don't want a bigger incision. It's just a 1 centimeter incision and take the vein out, ligate it and divide it. Done.
So it's actually there is no restriction for the Tumescent quantity. Even 500 ml is actually maybe used for both legs. If you are doing well.
In the Tumescent system?
That will aid in augmenting the anesthetic action and slow absorption.
Yeah, this Tumescent was initially advocated for giving local anesthesia because the procedure was not done under general anesthesia or spinal anesthesia. So it will give the local anesthetic effect also. That is why we are using more of lignocaine with adrenaline. That is why they were adding soda bicarboxylate, which we usually give for better action of lignocaine. That is why this thing was added. But now, why it is continued, even if the patient is under anesthesia? Because that solution, once you inject it inside and you touch the skin, you will feel a better cooling effect, which is not there if you inject plain saline. That you can touch and see during the surgery. That is why we are not discontinuing with the logs and we are not discontinuing with the soda.
Below knee region, the vein is superficial. So make sure we are injecting more of this Tumescent around that region. We can confirm the position and the compression of vein by the Tumescent under guided ultrasound guidance. Ultrasound will be helpful in entire procedure. And once the Tumescent infiltration is over, we can start ablating the vein using the laser. Additionally, we used to use ice also, along with or covered with a sponge, to give additional cooling effect to the surrounding tissues. And we will give a gentle pressure over the vein with the ice, so that the vein walls will be collapsed.
One last, any caliber of the vein beyond which we need not use the laser, better to use the open.
In case of
Here the exception also.
As long as you are ligating, the vessel size may not actually matter because you are anyway doing that treatment. It is instead of stripping, you are using this laser like that only. It minimizes. Typically, it's like a minimally invasive surgery, whatever these kind of modalities.
In one go, if it doesn't happen because the vein was larger, in one go it has not happened. You will do it the second time, right?
Okay.
So instead of
Once more, apply in the same area.
128 joules per centimeter of that.
our aim is to make sure the vein is collapsed, or by making the endothelium damage, using laser analysis.
It is 8 into 8 per centimeter.
Per centimeter. Joules will be the total energy delivered. We can adjust watt and time. Based on that, we can alter how much energy or how much joules is delivered. Laser probe is withdrawn slowly each centimeter. Again, if we are not getting enough catch, we can even remove the laser probe or withdraw the laser probe by half centimeter. So that will ensure more energy is delivered to that area and the vein will get collapsed. Laser will heat up the line of
energy, watt, joules. You should be very thorough about. Now we will tell only about varicose vein. It is 64, 36, 16 per centimeter. Right, that much energy, joules, that we are telling about. That it should be very clear. Because when it goes to proctology procedures, some procedures, they will advocate like this much of energy per segment of hemorrhoid, this much of energy per millimeter of pylorhinus, this much of watts, this much of joules, like that. And you should be very careful about what is being told, and only that should be administered, right? So now forget about proctology, just think about varicose veins. Joules per centimeter we are thinking about. It is not millimeter, it is centimeter. Okay.
When we pull out the fiber, we can hear that crackling sound, which can be appreciated real time using an ultrasound probe also, where there will be color changes around the vein, and we will get a resistance that we usually call a CAPS. Same procedure may be repeated for short saphenous system also. This one is already told. Sclerotherapy, we have already told.
And I'm gonna mix it over card.
Okay, sclerosant, which we usually use, is a sodium tetradental sulfate solution, and we will mix 2 ml of sclerosant with 8 ml of air using a 3-way cannula and 2 10 cc syringes. Proper foam is made, and we can inject it to the vein using a butterfly cannula. Using butterfly cannula, we will be injecting the sclerosant.
How much should we?
Maybe
How much is
2-3 cc only. If
at
it's small,
each spots?
each spot.
Each spots. We can again see to which all extent the sclerosant is going using an ultrasound.
Just assess
Make sure-
whether it has gone inside.
Deep venous system, if it is going, we should stop. So combination of procedures we are advocating based on the size of the veins. Saphenofemoral junction flush ligation with endovenous laser ablation is the best option, and foam sclerotherapy to the smaller or distal veins may be done. So that will be the triple therapy: SFFL, EVLA with foam sclerotherapy. This will ensure maximum outcome, best outcome to the patient. This one was treated with laser with sclero and SFFL.
In these kind of patients, you are able to pass the stroke easily.
It will be by manipulation, we will be able to pass.
You can see it today, because
Today's patient.
This is something.
a first patient is there for today.
Yeah. Okay. So thanks to our MIS department team. Thank you again.
Thank you.
We'll move to.
Yeah, we do have training
Thanks to-
programs. Yeah, training programs in all spectrum, like from endoscopic periodectomy, bariatric, all kind of MIS procedures. We do have a training center. If somebody is interested, you can contact our manager and pass on the numbers if you want. Or my number is there in the listing card if it's not there available too. Some of you. We are typical glorified general surgeons. We do thyroid one day, thoracoscopy another day, then bariatric surgery, all kind of hernias, everything laparoscopically, and these are fillers, like lasers are fillers for hemorrhoids and other things. I think you should start doing these kind of procedures. Then only the program is successful, your visit is successful. All the best. We'll go down to OT. It is ready. Yeah, you can leave that thing and then come back. Full രണ്ട് view ഉണ്ടോ? Full view. മൂന്നെണ്ണം കുഴപ്പമില്ല. മൂന്ന് view വേണോ ചോദിച്ചാൽ. Glass, don't keep it. Leave it for me.
stop sharing and
मेरे meeting finish आया था.
before the close.
Sorry.
Now next thing will be in operational.
I get back from.
This one I can leave, no?
Yeah, you can leave.